Well, good morning, everybody. Thank you, Taylor. I want to thank my colleague, Ed Hannon, who agreed to join us this week so that he could provide you some real life feedback from the front lines in Grand Island. We start the week within CHI Health with 270 hospitalized COVID patients across the state. That is up from last week. I think last week we reported 257 at this time. 75 of those patients are in the ICU. Again, that's up a couple, three, I think, from last week. And of those 75, about 32 are on ventilators. That's up a couple from last week. I'll hand it over to Ed to let him tell you a little bit about St. Francis' experience this morning. Ed, you're on. Got to get you off mute. There we go.
Us off mute here. Good morning, everyone. Thanks, Cliff, for the introduction. Thanks, everybody, for tuning in to us. As many of you know, yes, Grand Island was one of the first spots in Nebraska to receive COVID patients as the pandemic began, and we continue to see that. And being a hospital in the central part of the state, we serve much more than just Grand Island. Our service area really encompasses nearly 180,000 people in the central part of Nebraska. So as we look at our numbers, we really look at what's happening here in the central part of the state. Today, we have 42 hospitalized COVID patients. Now, those diagnoses are either their primary reason for being here, or several of these patients have other reasons for being in the hospital, and along with that health condition, also have COVID. So they're not here simply because of that. We currently have 9 of the patients in the division who are in our ICU, and all of them are currently on ventilators. We are seeing patients from across the state. Of the 40 patients that we have who do have a COVID diagnosis, about half of them reside outside of the greater Grand Island area as we get transfers in from other parts of the state. Taylor?
Okay. Thank you, Ed. We are going to open it up to questions now. We had several that were pre-submitted. And again, if you guys have been on this call in the past, you know you can chat questions and we'll do our best to get to them as time allows. If you have a question specifically for Ed or Cliff, please specify that in the chat. So the first question I have for you guys is, have standards for admitting/discharging a COVID positive individual changed as more people become hospitalized, especially when a COVID positive individual is doing well, but is of an older age or has concerning health conditions? We'll go ahead and toss that one to Dr. Robertson.
Thanks, Taylor. So the standards for admitting any patient to the hospital are really driven by the clinical status of the patient. So, you know, we within healthcare in this country spend a lot of time and effort making sure that we're utilizing resources appropriately. Hospitalization is one, and patients with the COVID diagnosis are no different. So just because you have a positive COVID test, and even if you're mildly symptomatic, that in and of itself is not a justification or reason to be admitted to the hospital. We do admit folks, and the folks that get admitted are ones that are exhibiting some instability. Either they require supplemental oxygen, or their vital signs may be abnormal, i.e. their heart rate too high, or their blood pressure may be low as a result of the infection. There are clinical criteria that drive the admission, just like there are clinical criteria that our clinicians and clinical teams follow to determine when somebody is ready for discharge. So we're not sending people, people don't stay in the hospital until they're, quote, 100% well, but we're also not sending people home that are too sick to be safe to be at home. And that is, again, that happens regardless of the medical condition or diagnosis.
Next question is, does CHI work with long-term care facilities on if they are able to take back in COVID positive patients? And I think Dr. Robertson and Ed can both weigh in on this.
Yeah, in fact, I'll let you answer, because you can speak specifically to your experience as a hospital president.
Sure, happy to do this. So we have always worked with long-term care facilities, even prior to COVID, on the continuum of care for patients, and it doesn't stop with COVID. What has changed a little bit is the Center for Medicare and Medicaid Services, CMS, has provided some regulatory requirements for how long-term care facilities need to operate during this COVID pandemic. And so our case management teams, which is made up of social workers and registered nurses in all of our hospitals, are in regular communications, daily communications with the long-term care facilities to say when a patient reaches that point of hospitalization, that they are ready for discharge back to the long-term care facility. We'll reach out to them and let them know the patient has met the criteria to go back. And that is generally means their care is well, and they have a test that says they are negative for COVID. They've gotten through that disease and are ready to go back. As time has progressed, CMS has said it's okay for long-term care to take back some of those COVID patients if the long-term care facility can be set up with a zone that is specifically designed to cohort all of those COVID positive patients together. So our care management teams across the system work with long-term care facilities and say, we've got one of your patients, one of your residents, and we'd like to get them back to you. And do we meet all of the criteria on both sides to be able to safely bring that person back? And so that's really done and designed because these are long-term care facilities, they're not hospitals. And we want to make sure that that staff at the skilled nursing facility, the long-term care facility, is safe and that they don't contract COVID. And we want to make sure that it is safe for the resident that we're sending back and all of the other residents that reside in that facility. So it happens every day.
The next question is, how is CHI preparing for extremely high levels of hospitalization? And I think you guys can both weigh on this as well, but we'll start with Dr. Robertson.
Well, this is something that we've obviously been planning for since early in 2020. We didn't see this level of hospitalization or hospital utilization back in the April timeframe, which was our first peak, if you will, although I wouldn't even call it a peak now, given that 107 patients back in the end of April is obviously a lot less than the 270 that we have today. But all health systems, all hospitals routinely prepare for disasters. And there are structures that have been put in place that are pretty commonplace across healthcare in the United States. So that as the pandemic started showing up and becoming clear that it was going to be a real issue for us here in the United States, we stood up our division and our hospital incident command. That model is a disaster preparedness model, and it has to do with leadership and structure and communication. More recently, we've been planning all along. More recently, we've been focused on staffing. As I've mentioned before, we've been bringing in agency labor, traveling nurses, and other health professionals from around the country. We're up to almost 200 travelers now in the organization. We've recently begun to scale back some of the non-urgent procedures that particularly for patients that would require an overnight stay. That's about 40 or 50 cases a day that we're not doing today that we were a few weeks ago. That helps free up staff. And quite honestly, Ed and his incident command at St. Francis, or our operational leaders across the health system, every day plans are changing, being modified as we have more information, as we try to prepare for what looks like might be ahead of us in the next day or two or week or two. Some facilities have done things uniquely, like set up their own, like COVID units, either at Midlands. I think Ed has done that at St. Francis as well. And we're obviously constantly monitoring our utilization of PPE, personal protective equipment, making sure that we've got the supplies and equipment that we might need 2, 3, 4 weeks down the line. So that's how we're preparing, and we've been preparing. Ed might be able to comment specifically on St. Francis's preparation.
So, one of the things, thank you, Cliff, is one of the things specifically we did here is set up what we call
Hang on one second, Ed, we're gonna mute somebody. There, you should be good now.
Great. So one of the things that we have done here specifically at St. Francis is one example. of many, many, many that have happened across Nebraska and Southwest Iowa and North Dakota in our hospitals, is set up what we call a respiratory fast track. So as patients present typically to the emergency room, as we come in the door, we're doing a quick screening and triaging them to say, if you're here for a respiratory illness, we're going to move you to a specialized area where we have a team of people and are really just focusing on the respiratory ailments. Many of them are COVID, some of them are not, but people don't know when they come here. That's why they come to us. And it allows us to keep the regular, if you will, emergency room patients, the traumas, the injuries, the heart attacks, those types of things separated in the other part of the emergency room so we can focus on the different types of care that we need to do. And that's one example of how through the incident command structure said, this is how we need to deal with the volume of patients coming in.
How exhausted are the nursing staff, physicians, and the rest of the staff? Ed, I think we could start with you on this one.
Sure, happy to. So no question, staff are tired. We've been dealing with COVID now since the early spring, and people are working hard. But that's what they do. It's what we came to healthcare for. We've really looked to say, how can we help our nurses get a breath, take some breaks, deal with staff that are out ill themselves or need some time off. And so across the division, we've brought in a number of staff to help us. We call them travelers. These are registered nurses, they're respiratory therapists, nursing assistants, to bring them in to provide a supplement to our staff. So in addition to that, people from all over the organization are stepping up and being asked to do something different. This is an all hands evolution as we're doing things. So people are being asked to do something outside of their normal job. People in finance, people in marketing, people in all of our support areas, those non-usually direct patient people are being asked to help. And so it may be a task that they do that is simply what we call a runner, somebody to go get supplies, go get whatever it is that nurses may need on the floor. So the nurses don't have to leave the bedside and do that. That's a tremendous help to the nurses. It allows them to really spend every minute, every day at the patient's bedside and not doing other tasks that other non-licensed nursing people can do. As we do that great work, it says we want to do it safely. We want to make sure that the staff get the education and the training that they need to do those new tasks that we're asking them to. We're in a division. We are very fortunate that we have a sufficient amount of personal protection equipment, so we can make sure that every staff member gets the masks that they need, the gowns that they need, what shields, whatever it is they need to do that new job, that they have to do it. So our nursing staff is tired. This is exhausting work, but we're supporting them in every way that we can to help them through the day.
Taylor, I'd add
just
to Ed's point, we've communicated to our teams that this is an all hands on deck moment. I heard yesterday that we've already had 400 of those ancillary shifts filled by our folks that normally aren't working in the hospital. So to Ed's point, these are our finance team, our marketing team, HR. They're doing everything from being screeners at the front door of the hospital to runners up on the floor. We even have some folks that are undergoing some additional training so that they would be qualified to even work more directly with patients as sitters. So some patients require, somebody to, be in the room with them on a more consistent basis. But it's been, heartwarming to see the number of folks that have already stepped up, and these shifts run 24/7, meaning some people are volunteering to come in and be in the hospital, through in the traditional night shift. So they're doing it to step up and help out the team members that are the ones taking direct care of patients.
Thank you both. So the next question is directed to Ed. How many patients need to be diverted out of Grand Island because of hospital being too full? And then we had something in the chat come up that's kind of related. How far away have some patients transferred from, and what added challenges does that create for both patients, families, and your staff? Ed?
Great question. So the transfer center, first of all, was in place long before COVID. It is a mechanism that CHI Health had stood up and said this is a really great way to support all of Nebraska and Iowa. And so any hospital has been able to call our transfer center and say, I have a patient that needs care beyond what we can provide here in our local community? And will you help us identify the right hospital to get this patient to and arrange for a physician to accept the care of that patient? So we took that concept that we had and said, CHI offered that to the state and said, for all of these COVID patients that we are dealing with across the state, let's all work together and appropriately identify the patients, where they're coming from, and where is the hospital that is best appropriate to take them, has the ability and the capacity to take them. And all of the hospitals across Nebraska have been very quick to adopt this and accept that this is a great way to do work. So yes, there are times here at St. Francis that we are getting close to our capacity. We always try and save a few beds for what we don't know might be coming in the door by ambulance or walking in the door in our ER. But there are times we're pretty full. And there are some days that I don't have to transfer any patients out of our facility. We're able to care for them all day long and get them the care that they need. There are other days that the right thing to do for that patient is to say they need a different hospital, a different set of eyes, a different physician to take care of them. While we have many, many great services at St. Francis, I don't have them all. As an example, if a patient comes to us who has a post-transplant patient, well, we're not a transplant hospital. That patient is probably best cared for where they had their transplant surgery. And so we will call the transfer center and have them help to arrange that transfer. So you'll see patients transferred in and out of hospitals for a variety of reasons, not just COVID. So I think that really speaks high to our commitment that we want to do the right thing for the patient and their family. How do we get them to the right facility, the right people to care for them? And as patients, they can transfer in and out. To the second part of that question, we have had requests from all corners of the state, and including some of the border smaller hospitals across the Kansas state line, to take some of their patients that are here. So I know that we've received them from, literally every corner of the state to bring here to St. Francis, and those are all arranged through the transfer center. I also want to say that the transfers that we do aren't always to us, but they're sometimes from us. There are times that a patient has progressed far enough in their treatment, they're doing very well, they'd like to be closer to home. So as an example, we may transfer a patient from here at St. Francis back to Broken Bow so that the family doesn't have to be so far away from them and they can be closer to their hospital. And so it's the right thing to do for the patient. So it's transfers in, transfers out. We typically at our transfer center right now, I think are doing about 12 patients a day out of the transfer center, if my numbers are correct, and I believe them to be. And again, that's from all across the state. As I mentioned, there are some days at St. Francis, I may need to transfer 2 or 3 patients. There are some days that I don't have to transfer any. When a patient receives care, we move patients from one level of care to another within the hospital. And so a hospital patient may come in and be in our intensive care unit to start with. They progress in their care, they're doing very well. I can move them to our PCU, a step down level of care, to free up the ICU bed that's now available. But if I don't have that bed available, then the transfer center is an option for us to get the patient to the level of care that they need. I think that answers both parts of your questions.
Thank you, Ed. The next question is, how is this surge different than the spring surge? Dr. Robertson, we'll go ahead and give that one to you.
So what I would just say is that, there's so much more information now about this virus, about what we're dealing with than we had back in the spring. While the volumes are up, while there are more patients, I just would tell you that it is a much different feel. If you're in the hospitals, you don't have quite the same level of kind of angst that you can feel or perceive from our clinical staff. We were worried a lot about ventilators and personal protective equipment in the spring. Those aren't real issues for us at this point. And so it's definitely different. I think also just the fact that our care teams have the ability to have some tools that they can use to treat these patients, I think is another thing that makes it very positive, a more positive feeling now than before. Now, that doesn't mean that the volumes don't create, a certain level of anxiety, given that we're, 2.5 times more patients in the hospital than we had back in April. But I do think the general sense is there's a lot more known. Folks are a lot more comfortable. This is a respiratory illness that, that the care teams take care of all the time, even before COVID even existed.
So if I can, I'd like to add to that just a couple of comments. Early in the spring, where we saw the infections coming from, where the spread was really concentrated, is probably a little different in the spring, or at least we're not seeing it like we saw in the spring. In the springtime, we saw it from multi-generational family clusters, people 3 generations all living under the same house. It is easily spread through those houses, or in tight work conditions, like in many of the manufacturing plants that are around, or meat packing plants that were around, where people were in tight contact in the working environment. We've taken care of that. We've learned that those things are a problem, and we've learned to deal with those and separate those. Where our patient population contact seems to be coming from now is in the small family gatherings. People do really well during the day at work. They're masked up, they're keeping social distance in their work environments, but then they go home and they let their guard down. So it's the small family gatherings that we have and that we're worried about coming up here as the holidays come, or it's the social things as we go out to restaurants or out to the stores where people aren't doing the right thing by wearing their mask or keeping distance from one another or washing their hands. So the contact is really becoming a bit different.
Thank you. Here's a question that both of you can weigh in on. Where is the system taxed? Ed, we'll go ahead and start with you on this one.
So where is it taxed? The simple answer is staffing. We know that nationwide there is a shortage of nurses, and we feel that here in Nebraska too. We certainly feel that at Grand Island. We have beds, we have physical plant available in most every hospital across the country. We just don't have enough staff to take care of them. So that's the easier. In Grand Island, we have 47 nurses that we are bringing in from outside of Grand Island or outside of Nebraska to help us in the upcoming weeks. We're doing that same thing throughout all of Nebraska, and I'll let Cliff comment.
Yeah, I just would add, as I mentioned earlier, we've got, I think all in, we're almost 200 now, and have more ordered that are in the pipeline. Again, part of our challenge is that we do have a number of our staff that are home on isolation or on quarantine because somebody in their family obviously got sick and tested positive. So now they are, being put under house arrest, so to speak, until there's been enough time that's passed, and we make sure that A, obviously they don't get sick, and B, that then it'll be safe for them to come back to work. So that number is around 2% of our total workforce that are at any given moment have been out either because they've been exposed and so now they're in isolation, or they've been ill themselves. So as we bring in additional staff, we're really doing 2 things. One of which is that helps at least maintain some existing capacity, but we're also increasing capacity. So for instance, at our Midlands Hospital in Omaha, I think next week we will be able to open up an incremental number of beds, maybe as many as 15 more beds we'll be able to open up because of the staff that we've brought in to help us out during this wave of increased infections.
We are approaching time, but I was just going to point out we're going to keep going because we have a lot of questions to still get to. So we'll do our best to try to answer everybody's questions. The next one is, there are so many rumors about not having enough beds and staff to care for sick people. How do you respond to people who are sounding the alarm? The hospital systems will be overwhelmed in 7 to 10 days. Dr. Robertson.
Well, so first of all, I don't know. There's a lot of noise that is out in social media that may or may not be relevant or even factual. I think the way we think about it is, first and foremost, panicking isn't going to change things and isn't going to help. So what I can say, because I get to see the professionals like Ed and his colleagues every day, they are, they don't know exactly what next week is going to hold. It may hold more patients requiring hospitalization, and they're focused on the things that we can do to be prepared to care for those in our community that might need us. The big piece behind all of this is really that, we as individuals, as Ed mentioned, the spread is occurring, pretty rampantly throughout the community. And we as individuals have a few tools. Now, at some point when the vaccines are out and widely distributed, we'll have another tool to control this infection. But until we have vaccines, our tools are these things like wearing masks when we can't practice social distancing, hand hygiene, washing our hands, very simple things. They are all individual, and those are the tools that we have and that we are, constantly reinforcing with our community, the power that those tools have to help us sort of stem the tide. We're not overwhelmed. I don't know that we will be overwhelmed, but for sure the general public can help those of us in healthcare by doing those simple things that while they may not be perfect, they actually do help, and quite frankly are something that we all should be practicing. I'll let Ed make a comment, but just the other thing is folks need to understand is we're 14 hospitals. So as the largest system in the region, we may look at this a little bit differently because it's hard for us to imagine that all 14 hospitals could all be overwhelmed all at the same time. You layer onto that, we're part of the largest not-for-profit health system in the country. So we've got 150 hospital colleagues around the country. So we have access to resources that we can bring to bear if needed. We have struggled with nursing, as we've already said, but we've been addressing that by contracting with external agencies to bring in these traveling nurses. So I think we're prepared to handle whatever the virus throws our way. What we do ask is that the general public try to do what they can do to mitigate the spread, which are these simple non-pharmacologic interventions that we've all learned about over the last 6 months.
Ed, did you have anything to add to that?
On mute. Yeah, just one comment. Cliff said that very, very well. And I think you're right. It's really in the public can do the most now to help hospitals, to help flatten the curve again here. It's in each individual's hand. Government doesn't have to get involved. It's really just do the right thing. The one other comment that I will ask that the public can do is to continue taking care of yourself. Don't stop taking your medications. Don't stop focusing on your own personal health so that your own health conditions that you may have don't get any worse and you end up in the doctor's office or in the hospital. So keep taking care of yourself and do the right thing.
Moving on to the next question, what's the nursing to patient ratio and how does it compare to what it would normally be? Dr. Robertson?
Well, I'll make one brief comment and Ed can speak to this. So, as an organization, we strive to follow, nationally accepted sort of nursing models. And those are for sort of normal operations, normal times. As we deal with more and more patients, those ratios of nurses to patients will by default have to change. And that's part of why we've created these other roles so that we can actually use other people that aren't registered nurses, as one example, to take tasks and work off of the nurse's plate to allow the nurse to focus on and really devote their time to the things that only they can do as professionals. And so, what this pandemic is doing, what any disaster, quite frankly, does is requires us to flex and to innovate how we deliver care so that we can, meet the needs of the patient. And folks can point to, what are the nursing ratios, but really those don't really matter as much when you get into a situation where it's not normal operations. We are, if we're dealing with a situation where we've got more casualties than in typical, we have to flex and innovate to be able to still provide great care. And that's what we're doing. I think that's what health systems all around the region and quite frankly, the country are having to do as they respond to increased volumes of COVID admissions.
So what I would add to that, Taylor, is really just a couple of comments to maybe give an example of that, where historically, maybe a year or two ago in an ICU, a nurse may have a couple of patients that they were taking care of. And if one of them had a respiratory issue, if they were here for influenza, the nurse would don or put on their personal protection equipment and go into the room, take care of the patient, come out, take off all of their equipment, and then go on to the next patient. Now, when we're doing that, we may have teams of people who are helping that nurse get into and out of their equipment faster, so they can do more in less time, spend more hours really at the bedside. Minutes make a difference. We have the same thing. We use technology differently. We have EICU equipment that can supplement. So if a nurse is in with one patient, the patient in the bed next door can be monitored and looked at through our EICU center that we have here at CHI Health.
The next question is, how does the number of patients in the hospital compare to this time of year normally? And I know you may have just touched on that, but if you have anything to add.
No, I would just say our census in terms of total people that are in the hospital on any given day, this time of year would tend to be upwards of around 1,100 or so across all of our hospitals. And we're not at that number. We're below that number. So, maybe a little bit less than we might see in the normal in a busy flu season. What's different is that we just have, 270 patients that have COVID as either a primary or secondary diagnosis.
Ed, did you have anything to add, or I can move on to the next question?
You can move on.
Okay. The next question is, how is treating a COVID patient different than a typical patient? Does it require more staff time, more resources? I've heard some folks in the community say the hospital is no more full than average, suggesting this is overblown. What would you tell them? Dr. Robertson, we'll start with you.
I would say that, treating COVID patients, and again, Ed probably can speak to this even a little bit differently than I can, but treating COVID patients is not that different than treating other, highly infectious diseases, respiratory conditions, which we do. What's different is what I mentioned is there's more of them in the hospital at any given time than maybe in a typical flu season, the number of flu patients that would be admitted. The average COVID length of stay seems to be a little less now than it was back in March and April. But it's still between 5 and 7 days, which means there are some people that are admitted, maybe require oxygen for a day or two, but then quickly turn around and are able to be discharged. And then there are other patients that may be in the hospital for multiple weeks. So, from a resource perspective, other than the personal protective equipment, I don't know that it's that much different, but obviously it's a little different than what we would normally experience because we are doing things like postponing non-urgent procedures. We're using more PPE. So I guess that's also a little bit different than what a normal November might look like in our hospitals. I mean, it is, this is serious. It's not overblown, the impact that this virus has had in terms of creating enough people that have been sick enough to require hospitalization. I mean, that's true. We're busy. The hospitals have a lot more of these respiratory conditions in them than we would in a normal November. But just in general, the way that these patients are cared for is not that dissimilar to taking care of other patients that have infectious respiratory diseases. Ed, do you want to add anything to that?
Yeah. So I agree. I wouldn't want to blow it out of proportion and start a panic, but this is serious. I mean, we are getting high in our censuses across many of our hospitals. The patients, as you said, the typical average, I hate to use that, but maybe 5 to 7 days. So there are some that are here a couple of days. There are some that are here 3 and 4 weeks, as like we established back in April and May, and still some of those patients today, although not as many. They do take more. As a comparison, probably prior to COVID, the average patient was in the hospital 4.5 days, where now the average is well over 5 to 7 days. So it does take more resources. They are here longer, and they're more in our ICU and PCU level of care, and not as many in our lower level medical surgical units. So it's intense. It is really busy in our hospitals, and we need people to take care of themselves so they don't end up here.
Ed, this next question is for you. What is St. Francis doing to support the mental wellness of staff?
Yeah, great question. So we have a very resilient staff, and they show up for work every day that they can. They're leaning in to do whatever we asked for them. And so, as previously mentioned, we said we need to supplement that staff. We want them to take time off. We don't want them to burn themselves out. And so the first thing we did is said, let's bring in some travelers and get us through this time where the people can get a break, they can get their days off. And so we're doing that. We are asking some people to work a little overtime, or we're asking all of our nurses to work overtime. So we want to make sure that doesn't get excessive. We've given access to our staff who want to reach out, or maybe sometimes we suggest that a staff member go talk to a counselor. They may be getting little signs of getting tired, and do they need to talk to somebody about either their stress, maybe because of the job, or maybe there's some other things outside of work that they need to talk to somebody about. So we make that available to them through our program. And we do have a hospital chaplaincy program here throughout CHI Health. So offer the opportunity for our staff members to reach out and talk to the chaplains here in our hospital. And then there's nothing better than, as we have programs built into the way in which we do work for reward and recognition. Do nothing more than say, thank you, let's take a break, give them a treat, give them a meal, whatever it may be, to just say thank you to the staff. And you'd be surprised just how far that goes to making the staff feel good.
Thanks, Ed. The next question, we'll start with Dr. Robertson. Is there anything the community can do to help the staff?
You know, besides the things we've mentioned in terms of wearing your mask and limiting the size of gatherings, I think I would just pile on Ed's comment that simple things like just saying thanks. If you know somebody that is a nurse or a healthcare worker, just acknowledging what they're doing and saying thank you. You know, we've had folks recently decorate the walks outside our hospitals again with chalk art, and just simple things like that really go a long way to just acknowledge those folks that 24/7 are there for the community. So that would be the one, you know, that'd be my one ask, which is just say thanks.
Ed, this question is for you. Assuming you use the EICU with COVID patients, has that been a useful tool?
Yeah, so it has been. So for those who may not be familiar with an EICU, let me just kind of briefly explain what that might be. In our ICU rooms, in each room in the intensive care unit, there is some very sophisticated camera audio equipment that is also connected to our telemetry so that it records the vital signs of our patients. It also connects to our center in Omaha, where we have a team of critical care nurse professionals and critical care providers who can monitor our patients remotely. They can see their vital signs. They can see the patient if we open the camera up and do that. And they can talk to the nurses and to the patients who are other providers who may be in the room. They have complete access to their electronic medical records, so they can see what's going on and see their lab values or whatever's there. So that's what an EICU is. It's electronic ICU equipment that monitors our patients. We use it in two ways. One is that staff is always there, and they're always monitoring that equipment, whether we've asked them to or not. They've got that extra set of eyes watching those patients. And with the artificial intelligence that's connected to it, we can do some predictive things that say, wow, it looks like the trends of this patient may be going in the right way, and maybe it's time to think about discharging that patient or moving them to the PCU, or maybe it's not going in the right way. Maybe their oxygen saturation, as an example, is not going in the right way, and we need to intervene. And they may see that in our EICU center before the nurse in the unit or the physician in the unit was in that room and didn't see it happening yet. And so they can intervene. They can then chime into that room. There's an announcement that says the camera is coming on and that they're there, and they can reach out to the staff and provide some assistance to the staff to care for that patient. So it's an extra set of eyes to be in that room. It's the same level of professionals that are in our ICU, but they can do that. The other way that it can work is that if a nurse is up there or a provider is up there, and maybe need some assistance, has a question, or just something doesn't look right and they want another set of eyes to say, hey, I want to bounce this off of you, can hit the button in the room and it alerts our EICU staff, and then they can chime in and provide that assistance. So we like to describe it as it's like having an extra team of professionals in our ICU rooms, in all of them at the same time, with their hands in their pockets. The only thing they can't do is touch the patient, but they've got the hands here in our facilities that can do that work. So it really is a great adjunct to our staff. And it is used not just for COVID patients, it's used for many patients who are in our ICUs.
And I would
This
just
next question, oh, sorry, go ahead, Cliff.
I was just going to add that, you know, it's a tool that we've had for years in CHI Health, and you know the power of having very experienced critical care nurses who are, you know, 24/7 able, with the assistance of the computers, to monitor those critical care patients is, you know, can't be undersaid. It is you know, it's a wonderful clinical tool that we have that, as Ed mentioned, is, you know, again, showing why we made those investments years ago.
This next question was asked of both of you, so I will let both of you weigh in. We'll start with Dr. Robertson. Does CHI Health think there should be a mask mandate for all or part of the state?
You know, a mask mandate, you know, mandate is a political word, and you know, we've taken the approach that as a healthcare system, as a not-for-profit organization, you know, we're steering clear of the political debate. What we believe is that individuals, given the opportunity with the appropriate education or information, will make the right choice, and that is the approach that we've taken and will continue to take. You know, just like, you know, there are other examples of people, you know, knowingly doing things that might, you know, have a harmful impact on their health. We're not going to be able to change an individual's behavior other than through education and communication. And so that's the approach that we take. You know, we've said it, I think, 5 times on this call at least, is that, you know, yes, there are people that make the argument that masks aren't perfect. They're not, but they are, that there is more data and more evidence even recently showing that wearing masks does limit the chance of an exposure resulting in a COVID infection. So we all wear them when we're in the hospitals or even in our administrative spaces and we can't social distance, we are wearing masks. So it's just the message that we want to continue to deliver, which is, you know, we wouldn't be telling people this is important if it wasn't important. And there is better science today to support the value that a mask brings, not only to me as an individual, but also to my loved ones and the community within which I live. And so that's the approach that we're taking as an organization, and what we hope folks will step up and do what we believe is the right thing for the good of themselves, their family, and for the broader community.
Ed, did you want to add anything to that?
Well, so I'll just add it. In the community conversations that we have here in Grand Island, it's really the same. It is, do we really need our politicians to tell us what we need to do? We know what the right thing is to do. And really where this comes from, where it should come from, is the grassroots. If every individual, every business leader, every business owner said, in order to use our business, we want you to wear a mask coming in, and you ask your employees to do the right thing when they're not on the clock and they're home, is to don't go to large social gatherings. If you're going out, wear your mask. That's where it needs to come from. So that's our message. We just all need to model that and do the right thing by wearing masks, keep our social distancing, use good hand hygiene, take care of yourself. And we don't need a government to mandate that. It should be a self-mandate.
So we want to be respectful of Dr. Robertson and Ed's time. So I'm just going to try to just ask a couple of questions here in the chat before we have to go. This first one I will direct to Cliff. This comes from the Lincoln Journal Star. Is the cutback in elective surgeries leading not only to more open beds, but also more staff members available to care for acute patients?
Yes. I mean, that's the reason that we would do it. That's the reason that what's different across the country this wave as opposed to March and April is we're not all health, we're not shutting down everything. We learned that and we knew at the time that was a risk, but the delaying of other necessary care has just as many negative health consequences. And so we are walking a fine line in terms of scaling back some of the procedures that we can scale back without a negative outcome to that individual patient, so that we can free up staff that we can utilize elsewhere, elsewhere in the hospitals. And so, yes, that's the whole purpose for doing it. Pretty much all the health systems around the region have embarked on this process of beginning to try to create some additional staff capacity by scaling back some of these procedures. And we will, continue to monitor the situation and make additional adjustments if we need to.
This next question I'll ask of Ed. How much do you think, and this is from KETV, how much do you think if people could spend a day at your hospital, they would better understand the situation we face? And where would you take that person so they fully understood the angst your staff is facing?
Yeah, I don't think you have to go very far in any door to see that, whether it be the emergency room and see the patients who are there to be treated. If you want to use what the media often does, is they use the most dramatic pictures, that would be in an intensive care unit. But we just need to trust each other to know that what we're telling you is the facts, is that this is a scary time. It is a serious disease. People need to do the right thing so that they don't end up coming here, so we don't overwhelm our healthcare system. We've been able to deal with it thus far, but we've got to flatten this curve again. And the only way that will happen is if all of the public leans in to do the right thing.
And then Ed, this last question that we have time for is also for you. With the new hospital being open in Grand Island, is CHI St. Francis seeing a shortage of nurses and staff?
Yeah, it's a great question. We have not lost a lot of nurses to the new hospital. The shortage of nurses is a national issue. It's not just because a new hospital opened a few miles away. So they will wrestle with the same thing we and every other hospital in Nebraska and every other state in the country is wrestling with. And that is, we really need more young people to enter the nursing profession.
Okay, thank you, Ed. That is all the time we have for questions, but I will let Dr. Robertson and Ed kind of give their final thoughts before we wrap up today. We'll start with Dr. Robertson.
I'll just reiterate that every hospital has a disaster plan. We prepare for, we practice, disasters, mass casualty events. A pandemic, while being, not one that we've thought a lot about, is really no different. As an organization, we're not driven by fear. We don't want the public to be, reacting solely out of fear. We want folks to do exactly what Ed said, which is to understand what we're dealing with, understand how serious it is, and because of that, then do the right thing so that we all can get through this this together. We're here to care for the communities. And quite honestly, I've been very proud of how the teams have stepped up, including now, our non-clinical folks leaning in and taking on, new shifts and new responsibilities within the hospital to help out our care teams. I guess it's part of being in the Midwest, whether it's a flood or a tornado, neighbors step up and help out, and we're seeing that within CHI Health and really across the entire region. So folks trust us to deliver great care, and we don't take that trust lightly. We're going to do everything we can do to make sure that folks that need us will have the care and access they need when they need it.
So,
Ed?
Yeah, so one final comment that I would make, having now lived in Nebraska for the last 4 years, there is something very wonderful about the culture of people here. and it really comes with healthcare across the country, but I really, really experienced it here in the Midwest. And that is, we truly are friends and neighbors taking care of friends and neighbors. And I am very confident that, we've talked a lot about today about staffing shortages and nursing shortages. And what I have experienced over the last, this calendar year is staff running in, staff leading in at all areas. What can I do next? What can I do to help? What is it that you need me to do? And they're all willing to do whatever it takes to take care of their friends and neighbors. People are running in to help, not running away. And so I'm very confident, very comfortable knowing that should this get worse in our communities, we certainly pray that it doesn't, but we're doing everything that we can to care for our communities, and our staff will be here at the bedside to care for everyone as long as we can. We'll bring in more staff. Everything that we can do, we'll continue to do. We're doing our part. The community's got to do its part.